Welcome to the Hologic Virtual Education Session, NovaSure Common Questions and Misconceptions. My name is Sarah Smith. I am the UK Marketing Manager and I will be your host this evening. Before we start, I'd like to cover a few tips about our virtual platform. At the bottom centre of your screen are several icons that will help. Each of the windows on your console can be resized and repositioned, so feel free to move them around to get the most out of your desktop space. For example, if you'd want to expand the slides window, you can maximize it to the full screen by clicking on the arrows in the top right corner. If you have any questions during the session, you can submit them in the Q&A window. If you don't see the Q&A window, you can click on the icon in the bottom centre of your screen indicated with a question mark. We have a Q&A session at the end of the presentations and we'll try to answer as many as possible. We also have a team supporting the programme today, so please use the Q&A function if you require any technical assistance. We have placed some useful reference materials, including the studies and information we are discussing today, in the resource list window, and we would encourage you to download them during the session. You'll have the opportunity to access your certificate at the end of the live webinar, and you will also receive a link in the follow-up email after the event. Finally, the on-demand replay of the webinar will be available and can be accessed using the same registration link that you used to join today. We are delighted to have two guest speakers join us this evening, Mr. Francis Gardner and Mr. Srini Vindler. Mr. Gardner is a consultant in gynecology and gynecological oncology based in the Queen Alexandra Hospital in Portsmouth. He is an advocate of minimal access surgical techniques and very instrumental in setting up the very successful outpatient service within the department. Mr. Gardner has several research interests, including screening for gynecological malignancies. Mr. Vindler has been a consultant in Obs and Gynae for over 20 years and is currently the Deputy Service Director for Maternity and Gynecology Division at Kingsnell Hospital near Mansfield, where he was previously Service Director for 9 years. He was one of the first clinicians in the UK to perform an outpatient MyoSure procedure, and he performed the 1 millionth NovaSure ablation also in the outpatient setting. Before we get started, we would like to request your feedback on our first poll. The question is, what are your top 2 concerns with patient selection for NovaSure? And you can select 2 answers. The options are post-ablation reaccess, post-ablation pain, long-term effectiveness, suitability for outpatient treatment, patient age, previous C-sections, obesity and PCOS, or if there's another option, and you can let us know in the Q&A box. I'll just give you a few seconds to answer that, and then we'll move on to our first topic. Just wait one more second for a few more answers. And the top answer is post-ablation reaccess, and also long-term effectiveness as well. So some of these topics we will cover this evening. So we'll move on to our agenda this evening. So the first topic is post-ablation reaccess and cancer detection. And as I mentioned at the end, we'll have a Q&A session as well. So on to our first topic. So I'm going to share with you some studies around this topic, and then we'll open it up for discussion with our speaker panel. Before we start, I'd just like to ask again for your feedback on what your percentage of patients do you feel return with postmenopausal bleeding post-ablation. So this could be your own experience or your potential perception. And the options here are less than 1%, 5%, 10%, 15, more than 20, or none that you feel are returning. So what is your current experience or your perception of the number of patients that may return with PMB post-ablation? So we'll get a few responses there, and then we'll explore some of the studies. So the majority feel around 5% of patients are returning with PMB post-ablation. So on to our first study. So this was conducted out of Bradford University Hospital, and the hypothesis was that by fully ablating the endometrium can improve outcomes by reducing the development of endometrial cancer. The objective of the study was to determine if it was masked or if it delayed diagnosis. This was one of the largest studies to date, with over 1,500 patients included over an 18-year time period. There was a range of ablation techniques included, and the majority were first generation at 67%, and NovaSure equated to 16% of the study group. The mean age of the patients was 48, and the mean follow-up time was 10 years. None of the women within this cohort developed endometrial cancer. The conclusion of the study shows there's no increased risk of incidence of endometrial cancer in women who had endometrial ablation with mixed risk factors. The next study was a symptomatic review from the Mayo Clinic in the US. This was looking at the issue of post-ablation scarring and the time to diagnosis. This included, again, a range of ablation techniques, including the majority of first generation, and 17 studies were included with 21 cases of endometrial cancer diagnosed. Of the cohort, so 35% of these patients were postmenopausal and they were being treated for PMB. The mean age of the patients at cancer diagnosis was 54. And the conclusion of the study is that all cases were diagnosed at stage 1, which is consistent with the general population. To reference the relative risk of endometrial cancer within the general population of between 2 to 3%, and those that have postmenopausal bleeding at about 1 in 10 or 9 to 10%. The final study I'm going to share with you is a study that looked at the increased risk of developing or masking endometrial cancer comparing to both endometrial ablation versus medical management. This data was taken from 495 practices within the UK and women over the age of 25 who were diagnosed with abnormal uterine bleeding. The average follow-up time was 4 years, and the patients had either endometrial ablation, medical management, or both. The results show that the incidence of endometrial cancer in the medical management cohort was 601, and in the endometrial ablation there were 3 cancers identified. This equates to 60 per 100,000 women for the medical management group and 19 per 100,000 for those who had an endometrial ablation. The 3 patients diagnosed with cancer in the endometrial ablation group were diagnosed at 5 months, 13 months, and 3 years. The conclusion of the study is that there is no increased risk or delay to diagnosis in both groups. I'd now like to open it up for discussion with our speaker panel. And I'll come to you first, Mr. Gardner, as a gynae oncologist, to share your thoughts on this topic.
So thank you, Sarah. I think the most important thing to take home from this is that performing an endometrial ablation certainly does not increase the risks associated with endometrial cancer. There may be a trend towards some protective effect, but what we can't say is that endometrial ablation does protect against endometrial cancer. And particularly for those groups of women that have a high risk of endometrial cancer, then that must be borne in mind when we're making a decision regarding potential treatment of heavy menstrual bleeding. So, for example, patients with Lynch syndrome, that group of patients should not be recommended to have an endometrial ablation. Those women should be considered for hysterectomy prophylactically. However, I think there's one thing that's very important. If a woman has had an endometrial ablation at a young age and she's been amenorrheic, potentially for more than 12 months, that doesn't necessarily mean she's postmenopausal. And if she resumes bleeding following a period of more than 12 months of amenorrhea, in this situation, I think it's very important that we evaluate the patient's hormone profile, because we may well see that the patient is in fact premenopausal, and this is just resumption of menstrual bleeding. However, if the patient is truly postmenopausal, then clearly that group of patients do need to have appropriate assessment and evaluation. Now, although NICE recommend that hysteroscopy is a better tool for the assessment of postmenopausal bleeding and heavy menstrual bleeding than ultrasound, in the case of a patient who has had an endometrial ablation, I would actually recommend they have a transvaginal scan as a first line. The reason being is if the endometrial echo is completely thin, then you can gain some reassurance that there is no sinister pathology. And it's very important you have an experienced sonographer who can actually ensure that they are scanning the whole cavity, not just in the main body, but also the endometrium out towards the corneal parts of the cavity. Now, if there is an area of abnormality on ultrasound, then I would agree that the next step would be to consider a hysteroscopic assessment. Now, as many of you will know, hysteroscopic assessment can be very challenging following endometrial ablation, particularly with NovaSure, because you get a very extensive fibrotic reaction within the cavity. And despite considerable time relating to trying to break down the scar tissue, sometimes it's just not possible to fully evaluate the cavity. And in that situation, if the patient is having postmenopausal bleeding, then that would be a situation where I would consider a hysterectomy if you can't fully evaluate the cavity and rule out a significant pathology. However, it is important to note that whatever form of ablation you use, there is a possibility that there may be some islands of endometrial tissue left untreated. And so endometrial cancer is a possibility following ablation later on in life. So, I hope that answers your question, Sarah.
That's great, thank you. And Mr. Vindler, what's your thoughts on this topic?
So I think Francis's point, Mr. Gardner's point about younger women who have had an ablation who recommence menses is very important. It could be that they're not postmenopausal. So if the FSH level is less than 15 and they've got an estradiol level over 100, you could say that they're still premenopausal, and that might explain the bleeding. I think The other thing that Mr. Gardner touched on is a risk assessment. So he said if you've got a woman with Lynch syndrome, then obviously they're not suitable for ablations, and you would consider treating them with a hysterectomy. I would add to that if a woman has had an ablation, you need to take into account risk factors as well. Type 2 diabetes, is she diabetic? Has she got a raised BMI? And if she's menopausal and she presents with bleeding, then you have to take these risk factors into account to think that there could be an endometrial cancer present. Now, the interesting thing is, from the studies that we have got, that we know that the majority of women who've had an ablation treatment are still, if they do have an endometrial cancer, the majority of them are stage 1, and that reflects practice in terms of hysterectomy and finding stages when women haven't had an ablation and have got cancer. The other very interesting point is that there's no delay in diagnosis from the studies. So if you suspect it, you do a hysterectomy, there isn't a delay in diagnosis. And also, the studies do suggest that in women who've got cancer, you've got a very good chance of getting a biopsy. So if you consider that endometrial cancer cells are unusual and they're growing, there's a good chance that you could perform a hysteroscopy and actually sample some cells and get your diagnosis that way. But I would suggest that risk assessment is really important in these women that we present in the postmenopausal phase with bleeding.
That's a common question we get asked regarding, being able to sample adequately, and any techniques or recommendations that you have. Mr. Gardner, any thoughts on that?
So in these situations, if the cavity is significantly fibrosed, which is the case in many situations, then I will always use hydrodilatation, because I think the benefit of direct visualization with hydrodilatation into the cavity, it actually allows you to identify the tissue, the potential tissue plane, to divide it with blunt dissection using the end of the hysteroscope. As Mr. Vindler quite rightly said, if there is a cancer there, then and they've revealed a postmenopausal bleed, then the reality is in the majority of these situations, you will actually have a tract that you can follow with hydrodilatation to take you through to the island of potentially malignant endometrium. So I would always recommend hydrodilatation in this situation. Another useful adjunct is also MRI. If a patient is suspected of having an endometrial malignancy following ablation, then an MRI is actually a very helpful adjunct, because if there is a focal area of thickening and it's associated with restricted diffusion, then that would give that patient a high probability of having a neoplastic lesion. So again, I would, in the main, try and use a hysteroscopic assessment, but if it's not possible to identify a pathology, again, an MRI might be a very useful adjunct.
Yes, I mean, I'd like to add that I actually think using that technique, you can even do it in the outpatient setting. It doesn't have to be under general anesthetic, because if there is a cancer there, as Mr. Gardner said, using hydrotic, water pressure really does help in terms of getting that pathway to where the cancer is. So I've actually used it in the outpatient setting. I don't know what Mr. Gardner does.
I do all of my hysteroscopies in outpatients. Last year, I think I did 2 inpatient hysteroscopies, and I would put an underline that by saying it's actually very much safer to perform a hysteroscopic assessment in the awake patient setting, because if you actually find that you're creating a false track as opposed to actually opening the uterine cavity, even with the use of a good local anesthetic block, the patient will let you know very clearly when you're directing in the wrong direction, because it'll become instantly more uncomfortable. So yes, I would say very much so. These challenging hysteroscopies really should be done by an expert hysteroscopist in the office or outpatient setting in an awake patient without any form of sedation.
So there's a very good question here from the group, from Rudran Reek, who says, obese patients are high risk to develop cancer, but also higher risk to suffer from surgical complications. Would you follow those up using scan only if access is unsatisfactory? How do you feel about that, Mr. Gardner?
Yeah, I think that's an excellent question. I was actually hoping to lead on to this topic of obesity. Sarah's already alluded to the fact there are risk factors associated with endometrial cancer, including obesity and diabetes and so forth. And in our risk evaluation as to whether or not an ablation is the right choice for that individual, I would actually say the combination of an ablation with a Mirena intrauterine system would be actually a very valid choice, because we know that the Mirena will protect the endometrium due to hyperestrogenic states and significantly reduces the chance of both hyperplastic change and neoplastic change. And it also has the additional benefit that if you place a Mirena at the time of ablation, it reduces the fibrotic reaction from the ablation and actually allows future easier access to the endometrial cavity. We have a number of patients that have had combined ablation with Mirena insertion, and many of those are now coming through to have their Mirenas changed after 5 years. And actually removing the Mirena, re-evaluating the cavity hysteroscopically prior to replacement of a Mirena is actually relatively easy compared to just trying to evaluate a cavity where there's been no Mirena. Conversely, if you fit a copper intrauterine device for contraception, what you will find is that actually the copper seems to promote the fibrotic reaction, and the copper devices can be almost impossible to remove. And so I would just recommend to the audience that should be considered as well when we're looking at contraception associated with ablation.
So I would again agree. I think putting a Mirena in, especially in a high-risk woman, for instance, with a raised BMI or type 2 diabetes, would be a very good management strategy in terms of reducing possibly the risk of developing endometrial cancer. And indeed, I think there are studies, especially from the Manchester group, aren't there, Mr. Gardner, that actually a Mirena and weight loss can actually reverse cancer changes in this group of patients?
Yes, Manchester group have done a study on this. There's also a group in Kent that have done a study where they just use Mirena without any kind of resection, and we ourselves in Portsmouth have got long-term follow-up now with women that have undergone MyoSure resection and fitting of a Mirena for treatment of endometrial cancer. And what I can tell you is that this is a very effective treatment. It prevents progression, and in a group of women, it actually cured their cancer because the women in our study, they actually were very unfit at the time of their diagnosis of the endometrial cancer and weren't suitable for hysterectomy. And when they were optimized with things like weight loss and optimization of cardiac function, we actually managed to hysterectomize some of those at a later date, several years down the line. And it was very interesting within that group, there are a number of those women who had no residual cancer. So Mirena is an effective treatment, undoubtedly.
So there's a very good question from a doctor.
Sorry, Mr. Vinner, I'm going to pause just there because I know I'm going to move on to the next topic. I know it's lots of discussion, but what we'll do is we'll bring some more questions back at the end. So I'm going to just move on to the next topic and then keep those questions coming. So before I do, I'd just like to get your feedback based on having listened to the discussions. Has this helped to alleviate any concerns that you may have had relating to post-ablation reaccess or delayed cancer diagnosis? And the answer options here are yes, definitely, yes, but still not completely convinced, no, I'm not convinced, or not applicable, I had no concerns in the first place. So feel free to pop your answers in there and we'll get some thoughts around that. And again, we can answer more questions at the end as well. A few more answers coming in now, and then we'll see what the responses look like. Well, that's good news. So hopefully some people have obviously found those discussions helpful. Right, so we're moving on to the next topic now, and this I'm going to cover a few indications, and then we'll have a discussion after a few study reviews. So this topic relates to post-ablation pain. There's a range of potential causes of post-ablation pain, and you can see here the list, and also within our 10-year literature review on NovaSure studies, it was shown to have a very low incidence of post-ablation tubal sterilization syndrome, or hematrometra, at less than 1%. The study I'm going to share with you is a retrospective cohort study with the objective was to examine the rates of dysmenorrhea after a NovaSure procedure in patients with and without known dysmenorrhea symptoms prior to treatment, and this was within a diverse population, and this was over a 6-year time period. A total of 144 women were evaluated who had underwent a NovaSure treatment. The mean age was 45, and there were 40% of the patients enrolled were African American, 11% had a high BMI of over 40, and a third of the patients had a normal BMI. The results showed that half the women had dysmenorrhea symptoms pre-treatment, and the majority at 69%. And the cohort had dysmenorrhea symptoms prior to the treatment, and this was reduced to 38% post-treatment. So 50% of the cohort saw an improvement in their dysmenorrhea symptoms. Also, they evaluated de novo, so new symptoms of dysmenorrhea post-treatment, and this was very uncommon, with just 3 patients at 7%. The resolution of dysmenorrhea symptoms was associated with a reduction in bleeding volume. The next topic is looking at NovaSure for women with adenomyosis. This French study evaluated 43 patients with a mean age of 47. The inclusion criteria was patients who were symptomatic with adenomyosis that were resistant to drug therapy. They had symptoms of dysmenorrhea and abnormal uterine bleeding, but they were considered suitable for a NovaSure treatment. The diagnosis of adenomyosis was based on ultrasound and/or MRI, and a questionnaire was completed before treatment and post-operatively at 6 months and 3 years. Pre-operatively, 77% of the patients had dysmenorrhea and all patients had AUB. Of those patients with dysmenorrhea, 74% had a pre-operative MRI, and of these, 59% showed to have diffuse adenomyosis, and 63% showed to have deep infiltrative adenomyosis. The results show that there was a significant improvement in both heavy menstrual bleeding and abnormal uterine bleeding, with 42% experiencing amenorrhea at 6 months and 37% at 3 years. There was a significant reduction in dysmenorrhea, and this was in 61% of patients at 6 months and 52% at 3 years. 8 patients, so 19%, went on to have a hysterectomy. 6 of these were due to persistent or recurrent AUB, 4 were due to persistent or recurrent dysmenorrhea, and 2 patients had both symptoms. All of the patients who had a hysterectomy had confirmed adenomyosis. Therefore, 81% of this cohort of patients avoided a hysterectomy. 56% of the patients who had a hysterectomy remained satisfied by NovaSure. And 90% would recommend the NovaSure procedure to a friend. The conclusion of the study is that NovaSure is an effective treatment for patients with symptoms associated with adenomyosis in both the short and longer term, and is a good alternative to hysterectomy. The final study I wanted to share with you is to compare the efficacy of NovaSure alone or combined with Mirena to treat abnormal uterine bleeding. The follow-up assessments were carried out at 6 months, 12 months, and 2 years. The primary outcome was amenorrhea, and secondary outcomes were treatment effectiveness, dysmenorrhea, patient satisfaction, complications, and rate of reintervention. Amenorrhea was significantly higher in the combined group, and the overall treatment effectiveness was 100% at 2 years, compared to 80% with NovaSure alone. 50 patients that were enrolled had symptoms, 50% of patients had symptoms of dysmenorrhea, but no patients experienced de novo or new symptoms of dysmenorrhea after treatment. The symptoms of dysmenorrhea were completely improved in all the combined group at all time periods. Reintervention was 1 patient at 2% at 2 years in the combined group who went on to have a repeat hysteroscopic reintervention. This was compared to 9 patients, 22%, in the NovaSure alone group. 4 had a transcervical resection of endometrium or repeat ablation, and 5 had hysterectomies. The conclusion states that NovaSure appears to be more effective when combined with Mirena for treatment of abnormal uterine bleeding and alleviating dysmenorrhea and reducing reintervention. And I'd like to open it up for discussion, and we'll start with Mr. Vindler this time and your thoughts on this topic.
So speaking from looking at my own cohort of patients having performed ablation for many years, I've found that actually NovaSure is a very effective treatment for both heavy menstrual bleeding and for dysmenorrhea. Of course, there'll be a small group in whom it fails. It seems to be in those, as the papers have shown, with deeper adenomyosis. There is a recommendation that if you suspect adenomyosis, that one should consider performing an MRI and looking for islands of endometrial cells within the myometrium. This could be used as a tool to counsel a woman. Therefore, one could say to the patient that an ablation treatment is very successful in terms of treating heavy menstrual bleeding, but the deeper seated the groups of endometrial cells are within the myometrium, there you can't give as much guarantee in improving the dysmenorrhea. That doesn't mean you can't try it. You could counsel them that it might not abolish the dysmenorrhea altogether, but for a lot of women, I find that just telling them that there's a good chance there'll be symptomatic improvement is enough for them to say, yes, let's give it a go. And I think the papers support this, really. So I'm a great proponent for saying, listen, adenomyosis and dysmenorrhea doesn't mean that you have to end up going down the hysterectomy line, that one can still try an ablation. I've had an interesting question on the group saying, can you put a Mirena in here? I mean, my personal view is actually I'm so impressed with doing ablation in terms of abolishing or diminishing dysmenorrhea as a symptom that I haven't used the Mirena, but I'd be interested to see what Mr. Gardner's views are on this.
Thank you, Mr. Vindler. From my perspective, I actually find that the Mirena intrauterine system is a very useful adjunct. And in my personal experience, as you know, I've been performing the ablations for over 10 years. Since we've started combining the use of the NovaSure with a Mirena, I've actually found that those women that had pelvic pain and also those women with confirmed adenomyosis on various types of imaging did significantly better with the combined approach. However, I totally agree that for those women who do not wish to have any kind of hormonal treatment, and that's why they've considered the NovaSure ablation. I think it's definitely worthwhile offering them the ablation, even if dysmenorrhea is a significant component of their symptom complex, because as the studies have shown and as in our own personal experience, it does have a very significant positive effect on controlling their dysmenorrhea component. I think there's also another group of women, though, that we need to be aware of. In many cases, patients that are labeled as having dysmenorrhea will actually have underlying endometriosis. And if you perform an endometrial ablation on a patient with endometriosis, that group of women do tend to perform badly. And their pelvic pain associated with menstruation tends to be unaffected by the ablation or have limited effect. And so again, in that group of women, I would strongly recommend further evaluation of these women with MRI, because if the MRI is identifying evidence of endometriosis, that group of women would benefit from having a Mirena as well as the ablation.
Great, thank you so much, and we'll answer any questions at the end. Right, moving on to the next topic, looking at patient counselling and patient choice and some COVID considerations. So this recent study that's published in August this year looks to compare effectiveness of NovaSure with Mirena. The primary outcome was blood loss at 2 years, and the secondary outcome was reintervention, patient satisfaction, quality of life, and sexual function. It was covered over 26 hospitals in the Netherlands and included patients aged 34 and older, and they were randomly allocated to treatment. Both groups show a significant reduction in blood loss, but however, NovaSure was superior with a P-BLAC score of 14 compared to 65. Women treated with Mirena were 2.7 times more likely to require surgical reintervention compared to NovaSure. Mirena was removed in over a third of the group within the 2-year follow-up, and 64% of these women went on to have a NovaSure treatment. The majority of the reinterventions were within the first 12 months for both groups. Satisfaction was high in both groups at 2 years. However, patients experienced higher satisfaction within the NovaSure group within the first 3 months, almost double compared to the Mirena group, 81% compared to 44%. The conclusion stated that women who start with Mirena are at an increased risk of requiring reintervention compared to those that start with a NovaSure treatment. There are some considerations when counselling patients to provide information on all the treatment options available and set the right expectation around treatment outcomes, with a clear focus on women's choice as outlined in the NICE HMB guidelines. Also, the recent COVID guidelines provide recommendations to consider the treatment setting, offering outpatient procedures where possible to reduce risks, and also consideration to future-proof services to reduce the backlog and future waiting lists without the reliance on theatres. I'm going to hand over to our guest speakers to go over this in more detail and share their thoughts. We'll come to Mr. Gardner first for this one to go through some of your thoughts.
So with regards to patient counselling, I think it's absolutely important that we do have a broad spectrum of treatment choices for women. Unfortunately, we still, certainly within my practice, still get many referrals to our service where it says this patient is requesting a hysterectomy. But if you actually offer all treatment options and explain the risks and benefits of the treatment options, there are many cases where individuals will actually see the benefits of more minimal treatment or less invasive treatment compared to hysterectomy. And I would certainly put to most women that the reality is that there are actually relatively few women that are not suitable for NovaSure endometrial ablation. One thing that's actually very important, though, to clarify is their fertility wishes. And we must be very clear that if there's any doubt regarding future fertility wishes, then a NovaSure endometrial ablation is not the right choice for that individual. And it's also important to ensure that we're actually discussing with a woman who has actually premenopausal and doesn't actually have postmenopausal bleeding or doesn't have undiagnosed abnormal uterine bleeding. Because prior to a NovaSure ablation, it's essential that if there is any abnormal uterine bleeding in a premenopausal woman, that this is investigated appropriately and endometrial pathology is ruled out. And I must clarify that for postmenopausal patients, the NovaSure ablation is an absolute contraindication. I think there's been a number of discussions regarding whether or not this would be an option for treatment, particularly with women with recurrent postmenopausal bleeding, but I must stress this is an absolute contraindication. With regards to COVID, then again, this supports the outpatient treatment very much more than inpatient admission. It's not only very clearly safer for the individual patient, but it's also safer for the staff as well, because we're avoiding interventions such as intubation and so forth. Srini, do you have any comments?
I think when a patient comes to us with heavy menstrual bleeding, requesting a hysterectomy, at least for those in whom primary care, within the audience, in whom primary care send these patients to us, I think a lot of the desire for a hysterectomy actually comes because it's the primary care physician who says, well, you have heavy periods and a hysterectomy would be the best option for you. So unfortunately, because I think primary care still aren't that au fait that there are ablation treatments available, which are in terms of safety, in terms of taking into account comorbidities, previous surgeries, dysmenorrhea being present and it being a very good treatment for dysmenorrhea, will come in because they've been preloaded with the desire for a hysterectomy because the primary care physician said this. So I think Mr. Gardner's right. I think once you establish why they want a hysterectomy, and it's actually the heavy menstrual bleeding plus or minus dysmenorrhea, and you go through options and you go through the pros and cons of each option, including how safe an ablation treatment is, I found in my practice that the majority of women actually choose to have an ablation treatment over a hysterectomy. Now, what we have to take into account since January 2020 is that COVID and our assessment of COVID and how we counsel women regarding COVID adds to the fact that I think we need to take into account, do ablations within the outpatient setting. There is plenty of evidence there that if a patient acquires COVID at around a perioperative period when they're having a general anesthetic, that the morbidity and mortality, unfortunately, in these patients is very high. And I think if we're counseling patients, we are obliged to tell them about COVID risks in 2020. And again, I have found that when I've done this, that women tend to favor having an outpatient treatment, and with adequate analgesia, including having staff there that are there to distract the women, and we can talk about analgesia for ablation if we have time. I think it's a very, very good treatment for heavy menstrual bleeding plus minus dysmenorrhea.
Thank you. And just to clarify, there's been a few questions relating to postmenopausal treatment with endometrial ablation. That is contraindicated. It's not the intended use, certainly for NovaSure. I think the study I related to was probably talking around first generation use for that potential indication. But yes, as agreed with Mr. Gardner, it is not intended for that purpose.
I think Mr. Gardner alluded to the fact that, sorry, sir, just very quickly, Mr. Gardner alluded to the fact that it's very important that we sample the endometrium before we do an ablation. You can do the ablation straight after sampling the endometrium, but it's very important that the endometrium...
to rule it out, absolutely. So the last topic this evening is talking about see and treat, or delayed planned treatment. And I'm going to hand this over to Mr. Gardner to give your thoughts around this topic.
So I'm a great advocate of see and treat. I believe that this is the way we should be moving our services forward. I've been trying to develop this concept within my own hospital for the past 10 years. And what we have to remember is that many of these women have suffered quite literally for years with their symptom. And you know, when they actually finally get to secondary care, what we should be doing is giving them the best possible treatment pathway. I believe that see and treat is safe. I always advocate performing a hysteroscopic assessment before performing an endometrial ablation. I know there are some centers that just perform endometrial ablation without hysteroscopy, but those are mainly performing endometrial ablation in the operating theatre. But as part of my local anaesthetic regime, we would actually place local anaesthetic hysteroscopically in the uterine fundus. So it actually becomes part of the actual local anaesthetic treatment as well. But if you visualize the endometrial cavity with hysteroscope, it's very clear if there's a suspicion of a significant endometrial pathology, and this can then be biopsied and a endometrial ablation can be deferred. However, if the endometrial cavity appears to be normal, then I absolutely agree we should be taking biopsies of the endometrium, sending them for histological assessment, but proceeding on to a NovaSure ablation at the time is entirely appropriate. If, however, a patient is ambivalent about which treatment choice they wish to pursue, then I totally agree that we should not be driving for see and treat. We should be focusing on the patient as an individual and offering the most appropriate treatment choices and allowing them some time to consider their options. I personally favour giving patients information around treatment choices for HMB prior to coming to the clinic, so that hopefully patients can come to the clinic informed and understanding what their desire is prior to coming to the clinic. And so consent associated with these definitive or permanent treatments can be established appropriately rather than making an on-the-spot decision. Mr. Vindler, what are your thoughts?
Well, I think your practice is actually one to be really admired. Our service doesn't quite match it, but as you say, if we follow nice guidelines, it is a very feasible thing. And again, I think appropriate counselling of the women is very important. The one thing that you have emphasised, and there's a question here from Dr. Peggy Kine, which has said that surely we need to look at the histology report before we embark on endometrial ablation. The one thing that we do need to do is get an endometrial biopsy. I think that's very important. I think there is evidence, there's plenty of evidence out there that doing an ablation treatment, even in the presence, say there is an endometrial cancer there, or even hyperplasia with atypia, that we are not upstaging that disease. So therefore, the treatment that Mr. Gardner's centre is advocating, which is a one-stop service, is possible even if we pick up there's a cancer or hyperplasia within that specimen. The ablation treatment will not upstage that disease.
Great. I'm going to move on to our Q&A because we've had lots of questions coming in. So I'm going to start with a few questions here. Looking at, I think you've mentioned before around removing a Mirena. And Mr. Vindler, have you done that? I know Mr. Gardner mentioned that as far as inserting Mirena and then being able to effectively remove them. Have you had a good experience with that, or any concerns?
So, I mean, I've had one or two where it is difficult to remove, but the majority, there isn't an issue. So, again, it's down to counselling, telling patients that in the vast majority of cases they are easy to remove. And if they are accepting of that, then I have no issues about putting one in at the time of an ablation. I don't know what Mr. Gardner feels about this. I know he's an advocate, but I wonder what his own experience is.
So I've not had any major issues at all with removing Mirena. There is sometimes a challenge if you're having a removal and refit to actually get the new Mirena to deploy appropriately. And so in that group of women where we're doing a removal and refit following ablation, I would perform a hysteroscopic assessment. And if the cavity is narrow and I'm concerned that the arms of the Mirena will not deploy effectively, then I would use the end of the hysteroscope to perform some blunt dissection to actually optimize the cavity. But, you know, in my experience, removing the hormone-releasing Mirena is not a significant issue. But as I said previously, trying to remove a copper intrauterine device is very challenging at times following hysteroscopic assessment, following an endometrial ablation. What I would also say, though, is if a woman wishes to have combined treatment with the NovaSure ablation and a Mirena, it is critical that the Mirena is placed at the time of the ablation. because if you try to fit a Mirena following ablation, even a shorter period of time as 3 or 4 weeks following the ablation, already the fibrotic response following the ablation is becoming well established, and it may not be possible to fit that device at that point. So we have to be clear that if a combined treatment is to be planned, then it should be done at the time of the ablation.
I completely agree with you there, Mr. Gardner. It's absolutely paramount that it's fitted at the same time as the ablation treatment.
So another question I have here is, what about women that are using tamoxifen? Mr. Gardner, do you want to start with that one?
So this is an interesting topic. The reason being is that tamoxifen increases the risk of endometrial cancer by 3 times compared to the baseline population. And evaluating the endometrium following tamoxifen stimulation is very challenging because ultrasound assessment is not reliable following tamoxifen stimulation, because you get permanent changes in the endometrial myometrial junction, which makes the appearance of the endometrium, of the endometrial echo by ultrasound, to be thickened. And so you will almost inevitably be in a situation, if you perform an endometrial ablation on a patient with tamoxifen, that if she gets further bleeding, there'll be a high level of anxiety relating to endometrial cancer because of the increased risks. And you will perform an ultrasound assessment which will demonstrate an abnormal endometrial echo. So overall, although tamoxifen stimulation is not a contraindication to endometrial ablation, I personally would not recommend it for this group of women. I don't know, what are your thoughts, Mr. Vindler?
I completely concur with you. And I think these days when you make these risk assessments, it's subtle things like this that we're really paid to pick up. You know, we are not mechanics. We have to think about the patient, the medication, and what risk that medication may have on this particular patient who wishes for an ablation. We know there's an increased background risk with tamoxifen, and I would counsel the patient appropriately that it's not that an ablation really isn't the answer, because you know there might be some issues about getting back in. There are issues about interpreting ultrasound scans, and we might then be looking at performing a hysterectomy on a woman who's fairly high risk, I think we're just asking for trouble. So again, I concur with you.
So I have one last question, and those that we didn't get a chance to answer, we will come back to you with some responses. So this is relating to the topic of adenomyosis. Patients that they usually have larger cavities if they are suffering with adenomyosis. Can this affect the outcome of a NovaSure ablation? I don't know what your experiences have been with that. Mr. Vindler, shall we start with you?
So I think you have to counsel a woman appropriately again. We know overall that the larger the cavity there is when you perform an ablation, that the treatment might not be completely successful. It then comes down to what is that expectation of that patient, and what's that expectation driven by. So if, as a clinician, I'm telling this woman, listen, I'm aiming for complete abolition of pain, and I'm also aiming for complete abolition of your menses, I'm setting myself up for failure. I'm setting this woman up to be disappointed with an ablation treatment as well. If I approach this as a clinician saying, listen, I will do this because you've got a larger cavity, I cannot guarantee complete abolition of menses, and because you have adenomyosis, I can't guarantee complete abolition of pain, but what I can give you is a good expectation that your menses will reduce and that your pain will get better, and possibly we can add some pain relief as an adjunct when you are having periods, how would you go for that, as opposed to all the risks of doing major surgery on this woman? I would suggest that a lot of women would run with that. I don't know what you feel, Mr. Gardner.
So I think the question is actually rather than relating directly to adenomyosis, but the large cavity. And the reality is that the overwhelming majority of uterine cavities, it is possible to perform an endometrial ablation, because although you may sound the uterine cavity and measure 10 centimeters, for example, or more, when you actually assess the length of the uterine cavity itself down to the internal os of the cervix, what you'll find is actually the overwhelming majority of patients don't have a cavity that's too large to be ablated. In the situation of adenomyosis, then again, it comes back to the discussion whether or not you would wish to do a combined treatment with Mirena. Because in that situation, even if there is a small part of the lower uterine cavity that's not been ablated, then the Mirena will still be having an effect on this tissue. But, as I say, I think that adenomyosis is, all of the published data suggests that the NovaSure endometrial ablation is a very useful treatment in this group of patients. And, I would support what Mr. Bindler said, that, I think that this group of patients do benefit from the NovaSure ablation.
Great. Well, we are out of time, but thank you so much. And like I say, we will get back to you on some of those questions that we didn't get a chance to answer. So before we conclude tonight's session, I wanted to make you aware of a webinar that we held 2 weeks ago and is available on demand. So it's covering how to successfully transition NovaSure procedures into an ambulatory setting. So if you'd like to watch the recording, you can use the link that will be sent on the follow-up email later this evening after this event. So thank you so much for joining us this evening, and to those that we have some international participants as well in different time zones. So thank you for joining us, and a big thank you to our guest speakers as well. That was great to share their thoughts and experience. If you require any further support or training, please contact your local Hologic representative, or you can email us at ukgynsurgical@hologic.com. And there's also some additional information and resources on our website, gynsurgicalsolutions.com. Thank you so much again, and hopefully we'll see you again soon.